at the medical school in Brighton, and I got goosebumps. I looked down, what's going on? I was in a lecture about treating alcoholics, given by a guy called Ben Sessa, who's a child psychiatrist working in Bristol. And his talk was like a call to arms. He was talking about a new tool that we have available right now, and he's treating adult suffering alcoholics with MDMA. I am an addiction psychiatrist. I'm Dr. Sarah Flowers. This is Charlotte Parkin. We both work in an abstinent space model. And this was uncomfortable, really, really uncomfortable. And there was a kind of come down. I thought, this is crazy. How can I be excited about a drug being used in recovery? I work in an adapted Minnesota model. I'm a huge fan, a friend of the fellowship, and I was confused. So this is 8 weeks ago. Over the 8 weeks, we have read, we have talked, we've talked to doctors in the field, we've talked to therapists, we've read books, and we've been up till like 3 a.m. because we're both mums, we're both working full time. We've been up between midnight and 3, reflecting about this stuff, talking about it, our feelings, our thoughts, our fears, our excitement. We're not experts in the field. I have no experience working in this area. I have 8 weeks of relatively intense probing into the area. So I don't have a particular attachment to it, but it's been fascinating. There's a lot of talk in the area about shaking the snow globe, using these tools to shake the snow globe, and it's kind of done that for me, and I think I could say for Charlotte as well. A lot of reflection, a lot of kind of soul searching in this area. So,
shall I show you the Bible?
The Bible, yeah. So this book. So someone early on recommended this book. Amazing book. It's fantastic read. I liked this guy before I knew that he'd done anything about psychedelics. He's an incredible storyteller, journalist, Michael Pollan. He's written a book. Since reading this book, he's been rated in the top 100 most influential people in the world. It's a fantastic book. There's an Audible, audio book version, Audible version. It's 13 hours long. I think I've listened to it twice now. But I would really recommend the book, and I have to say, you know, kind of what I've looked into is very much based on this book here. So it's kind of become our Bible. Okay. So a little bit about me. Oh, we both turned 40 during this time as well. Yeah, so we both I missed my 40th birthday kind of preparing for this stuff. So I grew up in a strange little town called Lewes. Fled to London age 18, and my medical training has been in London. Between London and Brighton, I've kind of been back and forth. And I trained as an addiction psychiatrist working in the NHS. I was one of the last generation of doctors to think about doing that, because there are very few of us left in the NHS. In fact, I was made redundant. So I was the addiction consultant for Brighton until April last year. And we've gone from a field of about 400 NHS addiction psychiatrists to about 10. So I've recently moved into the private sector. I'm working at LifeWorks, which is an adaptive Minnesota model. I have a history with AA. So I kind of first came to AA, first went to a meeting in 2006, and I've been a massive fan of 12-step fellowship from thereafter. All of my work, all of my teaching involves the fellowship, and I was served on the board as a non-alcoholic trustee for 2 years. I do a lot of kind of experiential recovery workshops, teaching medical students and doctors with the fellowship. So at the moment with LifeWorks, I work 1 day a week in the NHS as a consultant psychiatrist. That's me.
Thank you. I've not got quite an extensive career. I started out in the Priory in 2014 working at the North London Hospital, so very much abstinent, 28-day primary care. Then I started working at Harley Street and Fenchurch Street on outpatient one-to-one, and I've got a big passion about group work, so I'm trying to start doing a bit more of that. I was given this phone call 4 weeks ago, so again, I'm no expert on this. I'm just standing up to make sure you're aware of that. I'm literally just giving my take on this. As somebody that's literally just come to the literature, I had no idea there was so much out there at the moment about this. I think it's probably important to mention as well, I've never actually taken it. I am in recovery, but I have never actually taken a psychedelic, so that's something else to sort of take in mind of the way I'm looking at this. But I've gone on a bit of a journey with this. There's been some ambivalence, but we'll see how that goes.
Just a warning along those lines. You know, this stuff, in our experience, promotes a lot of discomfort. You know, we've had some very, very conflicting thoughts and feelings going on, and that's been over 8 weeks. You know, we've thought, we've talked, we've reflected, we slept and thought again. So in my experience, you know, I kind of had a lot of reactive feelings, kind of went away, created a bit more space about it, and I feel a bit more level. But I would expect for all of us that it you know, creates a lot of feeling. And as we say, we both work in abstinence-based frameworks and are not involved in any way, no funding, no active participation in psychedelic medicine at the present time, no sponsorship.
Thank you. Yeah. So Sarah's sort of, as she said, alluded to this. We've got no attachment to this, but I suppose I need to sort of talk about my passion of the 28-day program, which is my background and where I'm coming from. I see it as a bit of a reset button, the 28-day program. We're going to hear that word reset throughout the presentation, and that's probably where we might start to see this fitting. I see it as sort of a blank canvas. People go into 28-day when they're really stuck. It gives them a foundation for the rest of their recovery. The idea is you take away all behaviours and substances, of course. Not all of them, others come out. But the idea is it kind of sets the scene, and maybe a bit of a fast track. Some consultants call it equivalent to years of one-to-one therapy. So I think that's important to keep in mind throughout the presentation, actually, that we use the 28-day as a bit of a reset. So, okay.
Thanks, Charlotte. So what are we going to cover? There's quite a lot of kind of knowledge base. I mean, I kind of feel this is something that's happening. It's actually happening a lot more immediate to us than I had realised. And I had to go around and learn actually quite a lot of detail. And you might have to have a bit of faith because it's all relevant, you know, in terms of the content. So we're going to look at the definition of a psychedelic drug. What's a psychedelic drug? How they're used right here, right now. Then a bit about the historical perspective, because the context, the culture is absolutely everything, in my opinion, in this field. We're going to look in a little bit of detail about the psychotherapeutic process itself, what happens, how people are selected, what the process involves, and then why this stuff is relevant to us working in addiction. A little bit about the theory, not too heavy on the theory, but we're going to touch on that. Then we're going to look very specifically at 3 doctors working in this field at the moment, trip doctors if you like, and their experience. Again, we're going to delve a little bit more deeply into what is the psychedelic phenomenon, what are some of the experiences that people have, because it's salient to the therapy itself. Okay. Lastly, we're going to try and have a bit of discussion, maybe 20-30 minutes at the end. I hope it's going to get quite interactive. I'm sure there's lots of thoughts that we can have a look at, looking at the kind of risks and the benefits, kind of how we weigh this stuff up a bit. So what is a psychedelic drug? Psychedelics have been called lots of things in the past, and the literal translation of psychedelic is mind revealing, mind manifesting. They're wide and varied, and there's lots of different mechanisms of action. And there's 2 kind of main groups. One are the tryptamines. They're most of the naturally occurring psychedelic medicines, psychedelic compounds that are around. So that includes psilocybin, ibogaine, and there are also the phenethylamines. So those of you familiar with Alexander Shulgin, you know, he kind of took these compounds. The phenethylamines are based on mescaline, and changed the side chain. That included the 2CI, 2CB groups of phenethylamines. The 3 that we're going to look at in detail today are psilocybin, ketamine, and MDMA. Don't want to bore you with too much context, but as I say, context I think is really, really, really important. We're looking at, as a doctor, I'm looking at the approved, licensed medical use of these compounds. But the most of the use is in the kind of experimental, recreational area, and there's a massive kind of grey market. So, you know, these are illegal drugs. These are illegal drugs. They're Schedule 1 drugs, but they're used as medicines. That's pretty paradoxical and pretty pretty conflicting. Right here, at the moment, ketamine is licensed in the US for treatment-resistant depression, and it's going to be licensed in the UK later this year. So we're looking at S-ketamine, we'll talk about in detail a bit later on, but there are now ketamine clinics in the NHS and many in the US. Then there's this huge kind of grey market. This is underground. You don't know that it's happening, but there's a huge kind of network of people, underground guides, underground doctors using compounds that aren't perhaps produced by pharmaceutical companies and in paradigms that are quite different. So the Western model is the medical above-ground Western model is very, very different to the kind of more traditional shaman-based practices. So we've got these kind of different worlds, and they all interact. In fact, some of the people that have been behind the medicinal use of psychedelic drugs are really interested in the kind of wider social use and how that our culture might be changed, and kind of the environmental effects, the effects on capitalism. So these things are very, very interrelated. Okay. So a little bit about the background, and again, I don't want to bore you, but it is relevant. This is not new. The way in which these compounds are being used right now is very modern, but it's not new. So for the biggest period of time, what they call the first wave, particularly the tryptamines we talk about, have been used in kind of religious context, rites of passage, the kind of shaman-based use, ayahuasca, flesh of the gods. There are 200 psilocybin mushrooms that have been used perhaps for 7,000 years. So this is absolutely not new. The first time they started to be used as medicines was in the 50s, 60s, and there's a long history with this stuff. There were over 1,000 studies in the 50s and 60s using psychedelic medicines, and it was then that the paradigm of the psychotherapy with the psychedelic that was invented. So it's not new, and there are some people still active now that were active in those studies of the 50s, 60s. What is very different is the context, the culture. At that time, LSD was discovered in 1938, Albert Hofmann working for Sandoz. They didn't know what use that compound was going to have. And so Sandoz sent it out to anyone who was a researcher. That was a kind of very loose term, because it really could be any therapist, doctor, someone working in the field who wanted to experiment, use those drugs on themselves and with patients, and would write a report about it. So they were widely used. And there's a real rich kind of experience in that time. They were used with alcoholics, with obsessive compulsive disorder, with depression. The studies were very different in those days. We didn't have quite the same rigorous kind of methodology around studies, and we didn't have the modern tools of neuroscience. But still, there is a lot of information, knowledge, and wisdom, because some of those people working then are working at the moment. What was different was this culture of self-administration, and that kind of really, I think, was from the late 30s to about 66, when Sandoz withdrew the drugs. They were worried about kind of the cultural context that was emerging. So then it's, that things kind of halted, certainly above ground. People may have carried on using these compounds, but in terms of the kind of available evidence, started again in 1999 when a researcher called Roland Griffiths was given the first license since 66 to work with psilocybin. So his research has been going for 16 years now. So he's got patients that have been had 16 years of kind of psychedelic integration work. And we're looking at accredited, licensed studies, really good methodology, and using kind of modern imaging techniques. Just a little bit about that kind of shift across from the first to from the second to the third wave. So a lot of centres were active in the 60s, 70s, using psychedelic compounds. So the very first was set up by a man who came from Surrey, Humphrey Osmond. And he actually moved to Canada to do the work with psychedelics, and he set up the kind of modern paradigm with the psychotherapy that is used at the minute. But there were loads of people in the US, in the UK, across Europe, Israel, that had kind of really thriving clinics and treated lots and lots of patients. One of those was the Harvard psilocybin project, and Timothy Leary, working there, was a particularly kind of outspoken character. And this is where things kind of started to go downhill, because there was a kind of societal involvement, a kind of invitation for people to get involved in their recreational use, and people got really, really worried. To the extent that, 1971, he's described by Nixon as the most dangerous man in America. He's put in prison, and really, things didn't stop then, but they petered out. That was the kind of end of that era. So now in the modern age, things look very, very different. This picture on the right is Robin Carhart Harris, who is a really, really interesting guy. He has his master's in psychoanalytic theory, so that's his background, and did his PhD in kind of the neuroscience of psychedelics. So we're really looking at cutting-edge science, really, really sophisticated brain imaging of people on psychedelics, and rigorous, randomized controlled trials, comparing to placebo, to comparing to kind of best available medicines. There's an organisation called MAPS, which is the Multi-Agency. I'm forgetting there, Martin. Multidisciplinary Association for Psychedelic Studies. So there are networks of people kind of organised looking at this stuff. And just last week, Robin and Professor Nutt, who he works with at Imperial, opened the first psychedelic research centre in the world. So it's kind of happening here, right here in London, just down the road. There's also a big centre in Oxford, we'll talk about a little bit later on, and there's a lot of work going on in Bristol. So we're looking at psilocybin for depression, and MDMA for trauma is kind of the work that's happening in the UK at the minute.
Thanks. Well, I obviously wanted to try and find lots of media coverage to help me with my fear of all of this and my immediate reaction. And I was really surprised. I thought the Daily Mail would at least have something online. But no, there's plenty of stuff online about, I've got to look at this because the name of it, hallucinogen persisting perception disorder, and serotonin syndrome and psychosis and all things like that about kind of the dangers and harm reduction around this stuff. But there wasn't anything about the use of this with psychotherapy. Well, there was good stuff about it, but there wasn't anything bad about it. And I trawled. And there was BBC documentaries and all sorts of things like that, but none of it really resonated as being bad. So it was quite strange for my ambiguity to deal with this. So, thank you.
So what does the process involve? So in the very first, as I say, the modern use of these compounds is in a research paradigm. So there are a lot of standards, ethical standards, the kind of very careful selection of patients. So they'll screen out people with a high risk of psychosis, family history of psychosis, and then people are prepared. So they selected people with the condition, the disease that they're looking for, and the eligible people that haven't got kind of big susceptibilities to bad psychosis, for example. And then people are really carefully prepared. So a preparation session involves 8 hours of detailed preparation. Then you've got the psychedelic session itself. So again, that's an 8-hour session with 2 psychotherapists. The biggest part of the work, and I think this is really, really important, is the integration process. So that's something that happens in sobriety. It happens over numerous sessions in the weeks and months, and perhaps years following the psychedelic session. So during that kind of 8-hour preparatory session, it's really important to think about the kind of vulnerability of people going through this experience. It's a really profound state of psychic vulnerability. And there's a lot of talk about the ego strength that's needed to go through that process. And again, I think the setting, the dose, we're all really kind of familiar with those concepts. It's essential to think about that in this paradigm. The intentions are set. So, for example, you might be using psilocybin for smoking cessation. So you have a very clear intention. And Bill Richards, who's a guy that's probably guided people through more trips than any other person who's living today, talks about a conscious decision that in this set, with these people, with the preparation I've had, with the proper dosage, purity of substance, I choose to be out of control. So you can see how important it is to have that ego strength and that trust and rapport. There's not long to establish kind of rapport in this paradigm, but what there is, it's essential. You're trusting someone with your mind, with your sanity. Then people are given a really clear set of what's called flight instructions. So they're talked through some of the experiences that they might have. Ego dissolution, not an easy thing to explain, I'm sure, but it's important to be prepared for what might happen. Bill Richards says, if you feel that your mind is dissolving, that you're exploding, that you're going insane, go for it. There's this sense of kind of taking experience, holding on to it lightly, to trust in the process, to drift downstream, and to be open to whatever comes, the good and the bad. So to be open to the process of collecting experience during this session. In the actual psychedelic session happens in a hospital setting, so but it's a hospital setting that's kind of made to look like a cozy room, like the room of maybe a Freud or a kind of doctor that's travelled across the world. So there are symbols of all the world's religions. Here, this is the room at Johns Hopkins, Johns Hopkins Centre, which I think Martin's been in himself, and you can see here that you've got a kind of the mushroom stone here. You've got the Buddha, you have the rose. The rose has been used as a symbol since the very early studies, often used to kind of bring people back into the room, or if they need to go to the toilet to make that transition. So this is the setting. What you can't see is a kind of, the false ceiling of the clinic room above, so, but it's cozy, and patients are given an eye mask and music, headphones. And there's actually a Spotify playlist for psychedelic sessions. The music is apparently very, very important. A lot of thought goes into it. But it's a process of inward journey, which is why this sense of kind of going into the body with the eye masks on. You have two therapists, and these are very, very highly trained therapists. It's a very specific kind of setting here. Usually one male, one female. They're present throughout the experience. And they don't do much during the experience. They might jot down some of the experiences you have. They might put a comforting hand on you, and they're supporting the kind of the physicality through the experience. There might be kind of blood pressure, so on, monitoring that's required. And the dose and the purity, again, really well thought through. So these are, in the studies that Ben Sessa does, 99.98% pure MDMA at a very specific, adequate dose. So this is kind of monitored, supported medical intervention with two therapists that are strongly present with you, but the experience is one guided by the drug. It's not interventionist like some of the shamanistic kind of practices. There's a real respect, a kind of reverence for the experience of the drug. You don't get in front of the drug in this kind of paradigm. Okay, so I can't talk about the psychedelic experience because no two are the same, but there are some themes to come out of them, and I think it's important to hear from someone. So who better than Mike Tyson? So let's hope it works.
How long ago did it happen?
Around 2 months ago.
Yeah. Did you write down what happened after it happened, or did you record it?
No, I wish I did.
Yeah.
I wish I did.
Yeah, me too. Like it goes away like a dream, right?
It comes off, you're so scared, it starts off like this to me, like, no, yeah! That's how I start. No, I don't want to be this. I said, hey, I want this to stop now. And the guy was like, hey, you're on the ride. And I'm like, no, yeah! I love it. I love you.
Yeah, you love everybody.
Yeah, so spazzed out.
Yeah. Did you have a hard time letting go?
At the beginning, I was fighting it. I was saying, stop. I wanted to stop now. Just stop this shit now. Stop. And the guy was like, hey, the show was like, I can't do it. You got to go for the ride, dude. And it was like, oh, man, it's like I'm dying. Things are going on my face. I'm seeing the Aztec things. I'm seeing the toads. I'm just seeing weird animals and things. They're just flying. It's like another chamber. It's boom, flashing. You're like, boom.
Yeah.
And you gone. It's like a rocket. You taking off. Boom.
Yeah, it's beyond your imagination.
Yeah, it's inconceivable. Can't even explain it to no one.
Oh, let's go back.
Oh, sorry, do you want to go back?
So I thought that was a really interesting description, and some of the themes that are described in the psychedelic phenomenon are there. So you get these perceptual changes. I think we're all quite familiar with that, the idea of that during a trip, and they can occur at quite low doses. There's a kind of fashion for microdosing at the moment. The people that I talk to involved with the microdosing often talking about the kind of perceptual changes that they're looking for. You do obviously get states of panic, paranoia, confusion, but these are really rare in this medical setting. It's been quite striking to me how the kind of some of the things that I hold to be true of psychedelic experiences, bad trips, come downs, they don't necessarily happen. They don't necessarily, it's been surprising how little those things have happened in the trials. Then you get this kind of psychodynamic content. This might be age regression, sorting out of kind of conflicts, interpersonal issues. Then come, and Mike Tyson talks about this kind of visionary experiences, coming into contact with archetypes. He talks about the toad and kind of cosmic landscapes. The thing that really, really interests me, which I think is just fascinating, is these kind of unitive mystical experiences that you can get in a psychedelic state. And there's a sense that having had that experience itself is part of the treatment. Many of the studies, they found that it's the stronger the mystical experience, the more powerful the effect, so the greater the remission from addiction or depression. And they were really interested in this in the 60s, 70s. A lot of the studies were done by people who were active in divinity studies, and so they were interested in the mystical experience themselves. There was this famous Good Friday experiment run by Walter Pankey, and out of that kind of work came this rating scale. So rating scale, because the unit of mystical experience, we're talking about ego dissolution, ego death, so the non-dual states where the self dissolves, that subjective state dissolves. And there's kind of what's described as 6 qualities there. So they tend to be ineffable. In all of the studies, you have to write a description of your experience. And the kind of really common thing to come out of that is that it was really frustrating. I couldn't convey what that experience was. Words just didn't fit. They couldn't describe the experience. You often get very kind of paradoxical themes as well. This sense of transcendence of time and space. And I think, again, this is a very important kind of part of the therapeutic experience, that you survive the dissolution of time and space. The experiences are felt to be very intuitive, so rather than kind of going out there and experiencing something's been revealed, and it's just known to be true. No proof is needed. So it's a sense of something being revealed from within. They're found to be very sacred, and you get this deeply felt positive mood. I think Mike Tyson kind of says that, I love you, I love you, I love you, I love you. Again, you can't really describe it, but this very, very deeply felt joy. And the unity, this kind of unity that's experienced, can be either external, like a sense of unity with the whole universe, or internal, like you become one with gods, perhaps. But this sense of unity seems to be absolutely essential.
Okay, thank you. Thank you. Yeah, this is where I'm starting to sort of see some similarities in aim. I'm very much part of working individually with my clients and sort of helping people achieve their potential as human beings, which is obviously Maslow's hierarchy and needs self-actualization. And these are the 15 credentials for that. And I feel that Mike's sort of trying to articulate that, I suppose, in there. And it kind of seems to me there's something similar going on here. Obviously, some of our clients already have these, and sometimes it's for us to bring them out and make them aware of them. I think number 5 is particularly pertinent to me. Unusual sense of humour is something that I tend to come across quite a lot in the room. But yeah, I just wanted to say that because I'm starting to see something here now that started to make me think, oh, actually, there's something similar.
Thanks, Charlotte.
Right.
So then on to the integration, and this for me is kind of really key in this field. So often the day after the psychedelic session, there'll be a kind of the first integration session, and these are long periods of therapy. Bill Richard talks about making enduring light from flashes of illumination. So in that experience you kind of collected, you then wanted, you're doing the hard, sober work of making meaning from them. And it happens over a period of sessions, and it's a practice that you're really trying to make real, tangible, active change in your life. So it might involve kind of written work, sharing with other people, working on meditation practice, breathwork practice. And without that kind of integration process, to me, it's not psychedelic psychotherapy. You're really missing the key part. This isn't just taking a trip with your doctor. This is hard graft. You know, as we know, most change happens slowly, bit by bit. You know, in the kind of grey of sobriety over time. So that's the integration process. So how is this relevant to the addiction field? Well, the kind of first thing I think to look at briefly is, you know, do we run into trouble with psychedelics? Do we see addiction? Do we see problem drug use with psychedelics? For me, personally, there's something really interesting in how do these drugs work, because I think the things that we're understanding about consciousness and altered conscious states are really relevant to all types of recovery. Then there's the specific issue of the treatment of addiction itself, and there are a lot of people, and there's a kind of a growing evidence base to say that perhaps these compounds can be useful for the addiction. And I mentioned this relationship between the mystical experience and how powerful those effects are. So there have been, you know, 4 studies right here, 2 of them contemporary, looking at, you know, the stronger the mystical experience, the stronger the remission from addiction. I'm going to look very specifically at 3 doctors. So Roland Griffith, who works at Johns Hopkins, he's an academic. Ben Sessa, who's a child psychiatrist working right now in Bristol, treating addicts in the addiction service there with MDMA. And Rupert McShane, who's a general psychiatrist. He works in Oxford, and they run a ketamine clinic. The other area it's relevant is for the treatment of dual diagnosis, and there's lots that we you know are comorbid with addiction, of course, but the ones that really stand out as kind of prevalent and where there's an active practice at the moment, ketamine, which is due to be licensed for treatment-resistant depression later this year in the UK. It's already used pretty widely in the States. And MDMA for trauma, as I say, that's happening now in Bristol, on the through the NHS. You can be treated for your alcoholism with MDMA. So I think people are probably quite familiar with this as Professor Nutt's 2010 Lancet paper. I remember at the time, you know, being lectured by him, and he was dismissed by the ACMD for coming up with this kind of evidence-based comparison of drug harms. And you can see alcohol there's right at the top, and the compounds we're looking at right at the bottom. Addiction is not really heard of with psychedelics. I've worked in the NHS addiction services since 2003, and I've had 1 patient who's come with a kind of primary psychedelic issue, and that was extreme, really, really extreme for lots of different reasons. But this is not something we see in NHS addiction services. We're at the bottom of the kind of graph there. Not to say these drugs cannot be used in unhealthy ways, but they're not something that causes a lot of kind of externalized difficulty. This I found really hard to get my head around, so apologies if it's hard to understand. But this is probably the kind of model to be familiar with when we're understanding how psychedelics work, and it's a model that's come from Robin Carhart Harris, who works there at Imperial. So he is a super brainy neuroscientist, and he's also somebody with an in-depth interest, knowledge of working within psychoanalytic concepts. And he kind of relates conscious levels to entropy, so it's not an analogy that works perfectly, but it's really useful. And this sense that our available consciousness is restricted, regulated by a brain system that's called the default mode network. Default mode network is something I've had to become quite familiar with.
Noticed they got the wrong slides.
Okay, so we've got a typo there just to help simplify things.
Default mode network.
Mode network. So this is a kind of meta brain system. It's not a discrete area in the brain. It's a communication a system within the brain. And they first noticed it in 2001 when kind of doing neuroimaging. They noticed that actually, rather than be a passive state, there was an area in the brain that was really active. And it's where the brain goes at rest. It's where the brain goes kind of wandering, and it's where the brain does kind of mental time travel. What I did yesterday, what I'm doing now, what do I need to do tomorrow? It's some people have described it as the blah blah. It's also where we go to tend to compare ourselves to others, so the theory of mind. And it's thought of, Robin Carhart-Harris describes it as the conductor of the brain. So rather than this having a brain that's fully firing with kind of the bottom up and the top down, we have a top down suppression of information. So our sensory input from older areas of the brain is regulated by this system, which just lets trickle enough come through for us to function. It's something that's a facet of the more kind of evolutionary new brain. So it's thought that kind of more primary states that you get in childhood, psychedelic states, are of a different level of entropy. And it's a way of the brain organising, helping us to create some regulation with the amount of kind of information that's there in our subconscious. So it's been described as, it's like the ego, and maybe the seat of repression. It's the default mode network. Please do ignore.
The home of the ego.
The home of the ego, yeah. Okay, so that's a difficult concept, but kind of critical. And so in that way, the psychedelics have been found to actually take the default mode network offline. They reduce activity of the default mode network. That means you get more brain activity, you get more coming up from sensory input, from limbic areas of the brain. And you see on that when they've mapped the connectivity between brain regions, we go on to the next one. You know, the left is normal state, the right is psilocybin. So you get this greatly increased connectivity in the brain. And the idea, Robin talks about rebus, relaxed beliefs under psychedelics. So you get this very different conscious state, a more open, a less restricted conscious state. At the kind of molecular level, there's also some evidence to say that there's psychedelics increase plasticity. So that increased connectivity actually connects neurons at a molecular level. So kind of neurons that fire together, wire together. So having access to that increased connectivity, actually the connections between neurons, the dendrites, are increased. In terms of the work with trauma, Ben talks about a brain state that can be achieved by MDMA, that is that kind of optimum, that ideal brain state to do trauma work in. We know that in a traumatized brain, we have this hyperactive amygdala, this hypervigilant, anxious, traumatized state, which is led by the amygdala. Not only have that increased amygdala activity, but you also have decreased prefrontal function. And what MDMA does, amongst other things, is to quash the amygdala and to enhance prefrontal lobe function. So you're in a kind of neurologically assisted state to do therapy in. And we'll hear more from Ben in a minute.
Okay. So at this juncture, I feel important to sort of mention some of the commonalities that I witness on a day-to-day basis amongst my clients, and in relation to this really, and some reservations that have come up for me from that. First of things first, I notice a need to be seen by my patients. They come in and there's a real need. That's normally displayed by a hatred of indifference. If I sit there with a blank face, I get a sort of a guarded response. They tend to want to feel like I've got them, I think is the terminology for that. And this normally comes from a lack of attunement in childhood, so that lack of contingent, mirrored, marked response, which is my job, really, I suppose. When one hasn't got this contingent, marked, mirrored response, one doesn't find themselves in the caregiver, so you're left with what sense of like an alien sense of self. Fonagy calls it an alien self. And this alien self can come out quite sort of like a bit like fake, I suppose, or a bit inauthentic. And we'll notice that in the therapy room by what I call pretend mode, or what MBT calls pretend mode, which is where you'll be faced with a lot of intellectualizing, self-awareness. You know, the clients that have had a lot of therapy, but you don't really feel like you're really with them, ever. You get a lot of talk, but not really anything that you don't really feel you're actually with them at all. So from this kind of lack of feeling of self, you have a need for connection, which is why groups are so great. And to really know yourself, you need to be with other people. That's something I feel very strongly about. Something else that comes up is this need to escape yourself if you're feeling uncomfortable with yourself. And this is where drugs come in, firstly, to escape. But they also get this mystic power. They kind of get this ability to be the precursor for all enjoyment, for feeling alive, for feeling fun. When I ask clients, you know, when was the last time you really, truly felt excited? Normally they laugh and they, when I took drugs. I try and remind them of their childhood, and you know, the sad fact is some of them actually can't remember that sort of Santa Claus feeling. But I do try and remind them of that. So there's a big expectation with the drug, and that concern of mine, I suppose, around psychedelics is these are very, you know, there's a lot of expectations. They're very suggestive drugs. So the power's put in the drug. That's the key message there. Okay. And the last thing I kind of want to mention about the commonalities for this is the need to live in technicolor. Now, I've already offended a few people while I've been preparing for this, but my clients tend to come along and they're not the kind of Volvo driver. They're not the 9 to 5. They're not the kind of Barrett home fake grass. They're probably offending the whole room now. But this is how I kind of get to grips with kind of their mentality, and they kind of see life in technicolor. These guys kind of want to be, they talk about intense feelings. I love that. And I wonder, isn't that just something innate in these people? You know, isn't it just a gift? Do they need drugs? I don't know. So some of the concerns I have from this then, arising from that, was could the motive be maladaptive? And it doesn't really matter what the drug action is. What's the motive? And if the motive is, this is what the drug does, then, you know, this is where my concern would come. Because there are reports which we found, actually, that people say they have the use of the drug, and then they come out of it and feel a bit disconnected or disappointed in the world. And that's something I hear a lot, the world's boring, you know, this profound ennui that people talk about, and the word boring. And the drug could maybe give somebody a sight of something a bit more exciting, and then the world could really seem pretty grey when they come out of it. Also, are we judging addiction with this word ego? Mike talks about losing his ego in it. Now, is this really an issue with ego, or is it narcissistic wounding? Is this a lack of sense of self? And I feel there's a judgment in that word, like ego, and is it ego and spirituality, or do these people even have the ability to have transcendence at the point I work with them? You know, where are they at with this? Transcendence is that later stage development. So we're kind of expecting something of somebody that they're not maybe ready for. Maybe we need a bit of self-awareness from group before we can even get to this self-actualization. And again, finally, do we want to live in the grey? Maybe we need to find some joy in the normality and sort of be able to put up with some of that sort of greyness. I did actually do a little bit of research, or try to find some research into this ego dissolution that Sarah's alluded to, because this was my immediate response, was like, oh, ouch, ego dissolution, don't like the sound of that. And there is sparse, nebulous research around this stuff. The research that's done is done with very small sample groups, and we're talking about a very complex phenomenology, can't say the word, which is all subjective. And then we start getting into the philosophy of the mind, and what is the self, and what part of the self is being dissolved. And there are arguments that it's the sub-personal self that's being dissolved rather than the narrative default mode network that's being dissolved. And is that okay? And I stopped reading at that point. That was last week. And I said it's way beyond my pay grade. So, you know, I just thought I'd throw that into the mix, though, because it's something that started to really make me... I'm asking a lot of questions from this, put it that way. Okay.
Thanks, Charlotte. So we're going to look at 3 particular examples, and the first is Roland Griffith, who's an academic. He's a professor of psychiatry, a very, very, very well-respected, huge amount of research in the background in the addiction field before he started researching with psychedelics. And he was the first person to be licensed to do research again since the 60s. So in 1999, he started the studies again. And they tend to be in those conditions with which nothing else has worked. That's where you get the ethical approval. So treatment-resistant depression, treatment-resistant trauma, end-of-life cancer. He's looked a lot at smoking cessation, which we'll hear about a little bit more. He himself is a teetotaler. He's never used psychedelics. He has a 20-year history in meditation, and it was partly his experiences in long-term meditation that made him interested in psychedelic research. So there's some really common themes, and his kind of contemporary research, much of it looks at the similarities that occur in meditators and how meditators use psychedelics. Very, very interesting. So that's Roland Griffith. He works with this guy, Bill Richards, he was working at Spring Grove, one of those first centres in the 70s. So the two of them, you've got Roland Griffiths, the kind of erudite, teetotal, robust academic, and you've got Bill Richards, the man with the most experience in this paradigm, taking people through more legal medical trips than any other person. And they were at Johns Hopkins, where there's a very active research institute. Then we've got Ben Sessa. So Ben Sessa is a child psychiatrist. So he's come to treat adult addicts through the lens, the developmental lens of childhood trauma. And he's been very, very interested in the use of MDMA to do that trauma work. As I say, they have an open label kind of a tolerability study going on in Bristol at the minute. So it's not the kind of phase 3 trials that Roland Griffiths is involved in, but you can get treated with MDMA in Bristol. And we're going to hear from him. Rupert McShane is a general psychiatrist, and he runs what he calls a psychiatric intervention clinic, and that's in Oxford, in the hospital there. So patients are either treated with ECT or ketamine. So unsurprisingly, most of them want ketamine, pretty pissed off when they get the ECT. Ketamine has been approved for the treatment of treatment-resistant depression by the FDA in the US. There are now 300 or so clinics in the US where you can get intravenous ketamine. That's without psychotherapy. So hook up IV ketamine, 2 hours later you can leave the clinic. That's what's happening. I'm not saying it's good or bad, but it's happening. And later on this year, it will be licensed as a nasal spray. We'll talk a little bit more about that. S-ketamine, so they've taken one of the isomers of ketamine, and Janssen, the drug company, are marketing that pretty aggressively, actually. They think it's about $1 billion market there, ketamine for depression. So that's happening in the UK this year. Okay. So we're going to hear a little bit from Roland Griffith now.
So we've recently completed a study in 51 cancer patients with life-threatening cancer diagnosis who met clinical criteria for having a depression or anxiety disorder. These volunteers were randomly assigned to receive either a low dose or a high dose of psilocybin under double-blind conditions. Now, these results are still preliminary, but they're very promising. And what this graphic shows is the percentage of volunteers showing clinically significant improvement in depressed mood. The orange bar shows that 92% of those people who received the high dose of psilocybin 5 weeks after the session were reporting or were showing clinically significant improvements, much greater than the green bar that shows the effects after the low dose of psilocybin. The blue bar shows that the effects of this high dose of psilocybin are sustained out to 6 months. So about 80% are continuing to show clinically significant improvement. And in fact, in 70% of these, the symptoms have remitted to the normal range. We're showing similar effects for anxiety. These effects are really quite remarkable. What we're showing here is a single exposure to a substance producing substantial and enduring antidepressant and anxiolytic effects. such an effect actually is unprecedented within the field of psychiatry. Another population we've looked at are cigarette smokers seeking abstinence. These are long-term smokers, multiple failed quit attempts. In our first pilot study, 15 volunteers, we integrated a cognitive behavior therapy for smoking cessation with our supported psilocybin intervention. In this study, volunteers had up to 3 psilocybin sessions. The first session corresponded with their target quit date. And this graphic shows urinary cotinine, which is the major metabolite of nicotine, over the course of the study. You can see in the first 5 weeks, volunteers are showing high levels of cotinine, and that's consistent with the fact that this is the period where they're learning the cognitive approach to smoking cessation. It's prior to their quit date. Then we hit that target quit date, urinary cotinine falls dramatically, remains down. At 6 months, we have 80% abstinence rates. So like the cancer data, these data are remarkable because 6-month smoking cessation rates generally run in the order of 15 to about, the best, about 30%. So we're now proceeding with controlled clinical trials. Another population I want to talk about are long-term meditators. So I've come to think of meditation and psilocybin as being complementary processes for investigation of the nature of mind. And in fact, neuroimaging studies show that they both produce similar changes in brain regions related to a sense of self. Well, if meditation represents the tried and true course for investigation of the nature of mind, then psilocybin surely represents the crash course. And in this case, we're interested in whether long-term meditators are showing beneficial or perhaps detrimental effects of psilocybin exposure. Again, the data are preliminary, but I can share that most long-term meditators find these experiences to be remarkably insightful, and they report beneficial effects to both their sitting and their non-sitting awareness practices, although none would claim that psilocybin is a substitute for meditation, which results in much more stable day-to-day awareness.
Okay. The second doctor we're going to hear from, Ben Sessa, I've already mentioned, is in Bristol, and this is him talking about his experience with using MDMA for trauma.
I heard you speak a couple of weeks ago, and you talked about MDMA-assisted therapy as being like getting to the root of the trauma, whereas a lot of what the existing treatment does is more or less just trim the branches. Could you explain what you meant by that?
Okay, so I have come to the field of MDMA-assisted psychotherapy as a research topic through my experience as a clinical doctor trying to treat PTSD, and coming to the realization that the majority of the treatments we use are what I would call maintenance therapies. We paper over the cracks by treating the symptoms. If someone's depressed, give them an antidepressant. If they can't sleep, give them a hypnotic. If their mood goes up and down, give them a mood stabilizer. So I have patients who come in on long lists of medications, all of which treat the symptoms, but don't actually treat the root cause being the trauma that for most people with PTSD arises quite early in life, often due to child issues. So the analogy I make is that MDMA therapy is like an antibiotic that treats the root cause. So if you imagine having an infection due to a microorganism, you can take a paracetamol. That will lower your temperature symptomatically, make you feel a bit better. But paracetamol is not an antibiotic. And similarly, when we take antidepressants and the like for PTSD, we treat the everyday symptoms, but we're not treating the infective cause, if you like, the trauma. Yeah. But MDMA therapy is an opportunity to do just that, not treat just the overlying symptoms, but treat the underlying cause.
And you don't just obviously give out the MDMA as a drug, do you? It's part of a therapeutic process. Could you just briefly describe how it actually works?
No, you certainly don't just give out the drug. This is why it's the antithesis of current treatments, where you take these current treatments every day, day in, day out for decades, just to mask the symptoms. MDMA therapy, really, we focus on the MDMA bit, but really it's just an effective course of psychotherapy. So in a course of, say, 10, 12, 8 sessions, weekly sessions of psychotherapy, 2 or 3 will be MDMA assisted, and they will be all-day sessions, interspersed amongst non-drug therapy sessions in which you talk about the material that comes out on the MDMA.
And what is it about MDMA as a drug that is so effective at helping trauma survivors to confront what happened to them safely?
So I wrote a paper a few years ago called something along the lines of, if we were to invent a drug to treat trauma-focused psychotherapy, it would be MDMA. It appears to tick all the right boxes due to its very unique receptor profile. So at one level, it's increasing your mood and lowering depression and anxiety, which is important. It has a mild stimulant effect, which encourages the patient to engage in therapy. But it has a paradoxical, at the same time, relaxation effect. So that treats the hypervigilance symptoms. But its main effect really is this capacity to induce empathy. It allows the patient to engage with their traumatic memories that normally overwhelm them. So most people with PTSD, they'll do anything but think about that particular day, that particular incident. They'll do anything. They'll blunt their feelings with heroin or alcohol or self-harm or suicide. All of these dangerous behaviors basically to do anything but go there. And then on MDMA, they can go there. They can spend many hours talking through their painful memories without being overwhelmed with the normal fear response that goes with recall of those memories. So it allows a person, for the first time in their life, in many cases, to be with their trauma and talk it through.
I'm going to risk causing you a huge amount of irritation now by asking the question that I know you get asked a lot. Isn't this just like taking ecstasy?
So we have to be very careful to not infer what we know about ecstasy use and put that onto clinical MDMA. It's not at all like taking ecstasy. Ecstasy is whatever, I don't even know what ecstasy is these days. It's whatever dodgy club you buy some dodgy pill off some dodgy geezer. May or may not have MDMA, plus or minus many other possibly far more toxic substances. So for a start, the medicine we use is 100%, well, 99.98% pure MDMA. But it's the way in which it's delivered that makes it so different. When one takes ecstasy, it's all about externalizing the behavior, dancing, shouting, taking alcohol, lasers, loud music. So when one takes it clinically, you lie down in the dark with eye shades on and music with your therapist, and you use the energy of that substance to go inside and be with the trauma. Very different from ecstasy. And also, the risks that might be associated with ecstasy use can be reduced to a bare minimum when it's used clinically.
So where do we stand in terms of clinical trials and actually making this form of therapy widely available in the UK?
Well, at the moment, MDMA does not have a medical license. It's a Class A banned substance. So when we do the studies, we need to apply to the Home Office for approval to do them. And it's the same anywhere in the world. There's nowhere in the world where MDMA is licensed yet. We're looking at around about the next 3 to 5 years to get the studies completed around the world and see MDMA licensed as prescription medicine. But then, even when it is licensed, it's not going to be the sort of medicine that you can get from your doctor and then take home. It will only be, the license will be tied to having to receive it in a particular setting with a therapist.
Well, it sounds like it has potentially revolutionary clinical applications, perhaps for many people who have proved unable to benefit from our existing paradigm. So what do you think this could do in terms of transforming, if you will, the way we approach trauma?
Well, absolutely. I mean, the thing that interests me about PTSD is the 50% treatment resistance. The fact that for 50% of people, the current treatments are just not effective. And I think that's for a number of reasons. I mean, mainly because with all of those masking medications they take on top, the antidepressants, etc., when it comes to psychotherapy, asking that question, tell me about your rape, tell me about your assault, the patient flees. They drop out of treatment, they turn to drugs and alcohol, they have severe dissociative episodes because they just can't do the therapy. So it offers the opportunity for that 50% group to sit down with their therapist for the first time and do the work. So this could have really profound implications, because the trouble being that for 50% of people with PTSD, the disorder becomes a lifelong chronic disorder and they don't respond to treatments. So if we can in any way have a meaningful effect on that other half, then we're going to be doing some good things.
Well, it sounds fantastic. I'm going to put some links at the end of the blog to some more of your work for anybody who wants to find out more.
Okay, so you can see that...
I heard you speak a couple of weeks ago.
Shut up, Ben. You can see that the kind of paradigm that, the way that it's being used, MDMA is being used in Bristol has very much come from that kind of robust tradition at Johns Hopkins. And both of those compounds, psilocybin, MDMA, are in phase 3 clinical trials. So they think they might gain license 2020, 2021. So the data's not there to look at, but it's kind of watch this space. I have to say, think back to the goosebumps that I think were there for all kinds of reasons. One of them is the idea of something new, a tool. As a psychiatrist, we don't often get new tools, and it's so frustrating working with people who are not getting anywhere. And the idea of a new tool. Do you mind if I just wait for questions till right at the end? We're going to have quite a bit of time for discussion, I hope. The other is the paradigm. I think the paradigm is really interesting because I don't know of another, this sense of a kind of transformational experience that comes from one drug exposure. So this sense of kind of medicine and psychotherapy working together in that way. I often feel personally quite stuck in that kind of gap between the brainless, the kind of the psychoanalytic theory perhaps, and the mindless. And this seems to so beautifully bring those things together. So very much in that tradition. The third person we're going to hear from very briefly this time is Rupert McShane.
Hi, my name is Rupert McShane. I'm a psychiatrist based in Oxford in the UK, and I run a ketamine clinic. Ketamine's a really interesting drug. It's recently been found to be an antidepressant, and it's possible that that a version of it may get used clinically before very long. How does it work? Well, possibly up to 4 different ways. It's an analgesic, so it's got some action on pain, and of course depression is mental pain. We use these words for a reason. It's a dissociative anesthetic. That means that ideas that were previously connected become less well connected, and that can help people to gain new perspectives. It's a neuroplastic agent, so it means that potentially connections are easier to form, and it also seems to reduce the big break in your head that saps motivation when you're depressed.
So ketamine, as I say, is gaining license. It's slightly different to the other psychedelics in the sense it's a dissociative anesthetic, so it already has use as an anesthetic, long history of use, licensed use in medicine, and that's why it's a bit easier to use it off-label. So there's a current practice, with its use, and it's being used for a different indication, and that's kind of why perhaps it's not being used with the same rigorous psychotherapeutic element, because there's a leniency there because it's already used. I've spoken to all these doctors, apart from Roland Griffiths, over the last 8 weeks, and the thing that Rupert McShane was really kind of preoccupied was the risk, the need to have registries, maybe a bit like clozapine, the need for regulation. This is not something that the drug company want. Janssen don't want a registry. And he talks about them being substances with abuse potential. When I asked him, frankly, you worried about dependence? He is, and I think of the compounds, this is the one I'm most kind of concerned about, really. There are now 300 clinics in the US. You can have your IV ketamine from between $500 and $1,500, and there does seem to be a bit of a race to the bottom. The kind of the least human resource with the highest cost, and that kind of worries me a bit, because there's this dissociative effect with ketamine. It has psychedelic effects at lower doses, and it also affects the kind of excitatory neurotransmitter systems that sense of a rapid acting antidepressant. We don't have to wait 6-8 weeks that we do with SSRIs, that this is an immediate relief from depression. So it's intravenous, then oral, but then the licensed product is intranasal S-ketamine, so one particular isomer. Okay. Oh, no, not again.
Oh, no. There we go. Okay, so getting a bit reassured by these erudite individuals, and I'm thinking, well, how could I integrate this? I like to work in a multidisciplinary way with my consultants, and I work very individually with my clients, and I'm quite happy for somebody to go off and have a clinical assessment and come back maybe on some medication, because I find that they then they've had a shift and they tend to work better with me in some cases. So I'm certainly open to that. And also, could it maybe be a bit of a fast track, a reset button? Could it maybe get people where they need to get faster? So maybe could I use it instead of motivational interviewing? Or does it need to be something that's a sober choice? Does it need to be something once somebody's got abstinence? I think the important thing, though, is to realise that everything doesn't have to be so materialistic. And maybe I can learn from the abstinence volition effect, which is, we don't need to be quite so uncompromising, maybe, in our thinking around addiction. Start to sort of think about, where do we actually draw the line? My lovely stereotypes here of who might this work for. There are two I was sort of straight off, actually. I've kind of been thinking about this in my practice. And there's the good and perfect alcoholic, the one that says, oh no, I'll never take LSD. Oh gosh, no, probably me, actually, that's that one. And then there's the eating disorder client as well. The one that's really, really stuck in this kind of prison that they talk about, where they just can't get out of the control. But they know exactly what they need to do, but they just can't get out of it. So with these two, I feel like it would be a really nice way to help let go. But then I'm kind of brought into this flight plan idea, and would these clients let go into the flight plan? Would they surrender? I don't know. So that was I'm not sure about that one. Another client base is the trauma. Now, I've spoken to a few of my colleagues about this who specialise in trauma, and the general feeling is is a bit of concern around this with the MDMA, of course. And it could be maybe a way in to deal with those dissociated feelings in a more manageable way. However, the questions have arisen, should we let this out somatically? Should this be a gradual process? Is the client ready for this? Does it, is the connection going to feel real with the therapist? Is there attachment there? Is that strong enough? So I think there's a lot of screening involved in that one, and Sarah's sort of alluded to that. Another client which would be a definite no-no, I feel, is borderline personality. I think would be really great with attachment to the therapist and the therapeutic relationship, maybe. But this client, there's too much suicidal ideation, too much risk. They also suffer from something called psychic equivalent, which is where the inner world feels really, really real. And this client base actually has flashbacks in day-to-day existence. So the experience of a psychedelic drug might be really, really quite frightening for this client. The client with the attachment disorder, the one with the really sort of anxious childhood, when they've talked about taking LSD, one of my clients actually talked about it. She said that she came out of the trip and everyone was talking about this amazing awe that they experienced, and she was like, nope, didn't happen for me. So it kind of exacerbated for her the loneliness, a sense of disconnection with the world, because everyone else was having this amazing time on this drug and she didn't get it. So wondering how accessible this sort of awe would be for every client. Also, she sort of mentioned it being artificial. When she's taken MDMA, she said it felt very artificial and didn't feel real. And the next day, it's like, oh, that was just a drug-induced experience. And then finally, one that we both kind of agree on is the depressed, hopeless, helpless, stuck, depressed client who's resistant to all SSRI treatment, that kind of thing. Maybe somebody you're thinking about using RTMS on. This could be the kickstart they need. This could be the light. Again, though, I worry about expectation value there, expectancy value with these people who might think that they don't see the point, why, you know, they're so hopeless. So that's just a little sort of snippet really of how I think it could potentially work in practice.
Okay, I'm going to whiz through this one because we're running out of time. Just some thoughts about kind of the interface, because I think, you know, whatever we think about this, and there's a lot to think and kind of feel through it, but there is going to be an interface, because this is happening now, and how are we going to interface? Because clients may come to us who have had psychedelic psychotherapy, but they might ask us about it. They, you know, and you know what the kind of really obvious kind of conflict is one of abstinence. There's a predominance of a kind of abstinence-based approach in our treatment settings, and the drug is essential here. So how do we think about that? Do we think that the kind of drug use, there's a risk of kind of maintenance? I think with the ketamine, they're seeing these kind of partial remissions where they keep treating kind of indefinitely. Is that dependent? Is, you know, what's maintenance? And the need for safety and boundaries early in recovery. There's a really clear message that it's an abstinence message. There's no kind of equivalent of sponsor or psychedelic therapist that's available, and kind of really key for me is the community aspect. You know, part of the reason I'm so passionate about the fellowship is the community, the recovery community, and where is that for these guys? You know, there might be a psychedelic community, but are they healthy? And where's the structure? And where's the guidance? So that I'm worried about isolation. It's also financially, probably, let's face it, it's going to be very inaccessible for most people. It's going to be very, very expensive.
So yeah, I kind of see this maybe as the epitome of person-centered therapy. This 8 hours you've got to spend with a client, you've got to really, really, really be with them. We're working for the same aim. I think that's a key message here, that its abstinence is still the aim. All right. So maybe we need to sort of think about how this can maybe work together, because it's happening. So I think it's something we need to be aware of. So my takeaway from it is really, it's not a replacement for therapy, it's an adjunct. It's not a case of ego versus spirituality. We need to take that out of the equation. I think we need to get away from the modality conflict, which I think goes on a lot in the addiction world, where we kind of who's right and who's wrong, and see what could work together maybe. Also, it's not an abstinence debate, because we're both aiming for abstinence in both models. It's a proper medical paradigm here. But then I suppose my takeaway message as well is always, it always comes back to that attachment with the therapist, that need to be seen.
Okay, so just something about the elephant in the room. I've kind of, when I've been looking at these guys, I've been trying to work out, are you into psychedelics? You know, what's your is this for the validation of your personal use? This is what we're looking about is a licensed medicine that's an illegal drug, a Schedule 1 illegal drug. And, you know, the need for a therapist to have their own practice, an experience to be able to hold clients, you know, this is a kind of, it's a grey area, you know, it has a cultural context. Very much synonymous with the hippies and kind of what happened, some of that background that we looked at, and it's frankly competition. You know, there are people who are going to be setting up saying, we're treating addicts, this is new, it's modern, it's scientific, and we may feel a threat there. There's also something about the expert role, because in this paradigm, the therapist isn't leading, it's the drug. The therapist is holding, but they're not leading. And that might be at odds with our feeling. Let's whiz through here. So, whatever we think, we're at a cusp of something happening. We don't know whether it's going to be the same experience of the 60s, 70s. This thing's going to crash and burn. We're going to have some of the same difficulties. Whether this is going to become widespread, legitimate kind of mainstream medicine is yet to be seen. Ultimately, it's going to be high cost. It's not suitable for everyone. And there may not actually be that much enthusiasm to do it. You know, where I'm in Brighton, there's a lot of people who are interested actually in the NHS and elsewhere. But actually, when I've done surveys, not all psychiatrists have been that keen. So maybe it just won't amount to too much. The likelihood it's not going to go down well in your 12-step meetings. So where is the support? Where's the community? And just a bit kind of themes there for discussion. We haven't got very long, about 15 minutes. I know there were some hands up. I'm hoping that, okay, is that right? I go to this gentleman in the back who's had his hand up a while ago.
My question is regarding MDMA. It's the slide that you have had talking about was MDMA, and PTSD. You know, is there also a trial regarding MDMA and alcoholism? Because your slide suggested MDMA and alcoholism.
Yeah, so there probably is. Martin here is nodding. Are you, Martin?
Well, this Spain study.
Yeah, so, oh, sorry, yes, absolutely. The study in Bristol is MDMA for alcoholism. So they're using it within an 8-week inpatient, outpatient therapeutic model there.
So MDMA cannot be prescribed. Is X-amphetamine, which is prescribed, can it be used as a substitute?
But MDMA can be prescribed because it's being prescribed within research projects. So that's how this... It's not a psychedelic, no. It doesn't fit into the psychedelic as we see them now. Yes, please.
I'm just a little curious. I've been kind of working in this for 40 years. Why didn't you include iBook?
Okay.
Because I just want to point out two things. The National Institute of Drug Abuse did a 4-year study of ibogaine. None of these other drugs got that treatment from the American NIDA. 2, ibogaine is the only drug we can give when somebody wakes up in the morning and they're in withdrawal, where after 30 minutes, the withdrawal goes away, and after the ibogaine, it doesn't come back. This is an enormous thing for opiate users. Also, it is effective across a broad range of drugs because it expresses a nerve growth factor called GDNF. So it's resprouting dopamine receptors so that you can feel your dopamine again. Why didn't ibogaine make the cut?
Only because we just had 90 minutes. So that's purely that, and it's really, really interesting to hear that stuff. So we just focused on those 3 main compounds, and they're the ones that most tangibly around me as an addiction psychiatrist at the moment. So psilocybin, MDMA, and ketamine, just purely because it's an immense field. I could quite happily progress to study, do a PhD in this area. I think it's fascinating, but just to contain the area. So I'm not saying that, ibogaine might be equally more interesting than all of these compounds. It's a really diverse, rich area, but we just haven't had the time to look into everything.
What's the only thing that really competes with standard treatment?
And I know there have been other talks, I think, on
yeah,
ibogaine.
there was, and I just wanted to interject because I asked you this about the craving thing, because that's a whole other discussion, isn't it? The withdrawal side of it, and I think this is more pertinent because of the NICE guidelines and the fact that you were saying these are the ones that are going to be legalised more in the UK.
Yeah,
so this
just
is sort
for
of
brevity. That was the only reason, not because it's not important.
It is number 2 at MAPS, right behind MDMA.
Thank you so much. Yes, please.
Hi, I'm Rachel. I'm a double winner, and I wanted to make a couple of comments. One, I praise you for looking into this and doing such a in-depth look at it in such a short time period. I've been studying psychedelic history in the 1960s since 1992, and I will tell you that the scheduling of the drug is a cultural political reaction to the potential for anti-capitalism, and it goes back even further than that. Look at Ayurveda, look at traditional Chinese medicine, look at the mushroom cults that exist in Mexico. To say that it has not been used medically, I think is a disservice to plant medicines and plant teachers themselves. And before I turn over to Dr. Cameron, it also reminds me of a discussion I had in my first year religion class in undergraduate, and the question was, are you experienced? When we were reading Carlos Castaneda. I get asked this all the time. I have not done ibogaine. I advocate for it as a treatment facilitator. But I think the fundamental question of do no harm is kind of what I see animating your inquiry here. And there's a really good book on the Harvard Psychedelic Club. Did you look at that by John Martin?
I haven't read it, no.
Peace and Recovery. He's a former religion editor, journalist at San Francisco Conference with a bunch of stuff on the psychedelic culture. And the stigma of what the tie-dye tar brush does to the word hippie and the role of the pharmaceutical companies in putting that schedule in place. I don't bow down to that state apparatus. That's what's real medicine.
Thank you so much. And you guys are way more learned, experienced, absolutely. We're just coming to this from a doctor-therapist experience now, and I found the kind of political, social stuff so interesting. I'm not saying the traditional healers, there's not healing there, but it's a different paradigm. It's a very, we're looking at a very specific point in history that's a tiny bit of history compared to the depth of knowledge and practice, throughout our human culture. So absolutely, I'm sorry if that came across the wrong way, but I'm looking from a doctor, please.
Making a huge mistake here if we call MDMA hallucinogenic drug. It's not in the category with those other drugs. It's an adaptogen and it's a tactogen. It is not taking you to a safer place. It's a place where you're getting in touch with emotions, and it shouldn't be grouped with these drugs, which are really life-changing spiritual experiences with a sense of really traveling to a place. And somehow MDMA got grouped into this word, hallucinatory drugs, and we're trying to change that word into entheogenic drugs, because hallucinations are what schizophrenics are having, the wrong associations, and this is anything but wrong associations. So we're about 2 years in the U.S. through MAPS and the Rick Dominance work and getting an MDMA for PTSD with trained psychotherapists doing this. I've been doing ketamine treatments in my office for 2 years now, and the results have absolutely just blown me away after a single treatment. We're also using it for post-acute withdrawal syndrome on patients who are in detoxing off narcotics and alcohol, and I found it to be of great value. Another thing to remember that many of these drugs, some of these drugs have no LD50, like LSD. Did you do 100 micrograms or 20,000 micrograms? Nobody's overdosing. On drugs like ibogaine and ayahuasca, there are lethal dosages, and there's a dose-dependent response. So I know all these doctors. In the psilocybin study, those people who took a little bit of psilocybin and took a lot of psilocybin had a very different experience. And also in those 15 patients that we treated for nicotine, they got so much psychotherapy that I'm not sure that psilocybin did anything to abate nicotine withdrawal symptoms, and ibogaine doesn't either. But was it all that love and attention given because they had so much pre and post psychotherapy to create the results they didn't want to disappoint my studiers? But I think we're on the dawn of a new age here, and our biggest problem is, at least in our country, and I don't know about your country, is big pharma's reluctance. How are we going to make money off these drugs if these treatments work? Nobody is going to abuse hallucinogenics. They're not substances.
You don't go home from work and take them.
Really good idea for anybody. I have to warn you. The only people who shouldn't take it if you even sense that the patient may have any schizotypal disorder, even somebody who might once every 3 or 6 months, don't give them any of these drugs. You're not going to have a good experience. And if you haven't had that experience yourself, it's really hard to tell them how to manipulate in that space. How do you manipulate in ibo space or psilocybin space or DMT space? And last recommendation, there's a great little video you can get on YouTube called DMT, the Spirit Molecule. It's a great primer into what all of this is about. The hardest part we're having is fighting, getting DEA approval on political approval to study these drugs, because they're cutting into big pharma's profits. No drug is a good drug.
Thank you so much. And I agree. I mean, the reason I chose partly those 3 compounds is they all have such different mechanisms of action. And I think it is curious that MDMA has been grouped as a psychedelic, because it doesn't act on the 5-HT2A like the other classical psychedelics. The effects, the experience, the interaction with therapy is very, very different, yet it's being grouped in the same way. And the ketamine, again, I'm really curious why I don't know in your studies, is the ketamine...
It's very dissociative. So thinking of hallucinatory world, ketamine is like putting your toe in the pool to see what the temperature is. Taking LSD or ibogaine is like jumping off the high diving board into the
it's a very good little introduction into people who are naive into what traveling into inner space is about. It's got a wide therapeutic index, so you can't kill anybody if you wanted to. We used to use ketamine as an anesthetic for infants and animals because there's no, you can't overdose on it. So you start low at 1 milligram per kilogram, and the second treatment you go up to 2 and 3 milligrams per kilogram. People are having profound spiritual experiences where they're questioning what is real. And I always say to people, if you don't think where you're going to under these substances are real, then what's the most potent hallucinogenic substance on the planet? And people start to take 2CB and this and that. They say, no, it's oxygen. If your oxygen away, this is going to disappear. And where you're going to there is just as real as this. And if you've had that sense, so it's very important to give the patient instructions. I say, if I knew how to fly an airplane and we didn't, and I jump out with a parachute, your experience, it's not going to be a very good experience.
So would you say the experiential is important then? So the therapist needs to have experienced this. Would you say that was quite key?
Yes,
that's where,
certain.
absolutely, yeah.
I'm not so sure on certain particular substances like low-dose psilocybin, no, maybe not on MDMA. But we are talking about things like iCAAD, LSD for end of life. If you haven't had this experience yourself and you're going to try and give somebody instructions how to operate in that space, and there isn't language to explain it. There really isn't. It's so outside this paradigm. Nothing I can say to explain that experience to you unless you've had it yourself.
I watched this Jamie Wheel video yesterday, which was really interesting, a bit late to kind of integrate into the talk, but he was talking about, he'd been to a MAPS dinner with a psychiatrist who'd been a general psychiatrist who was kind of frustrated with the tools of, SSRIs and trauma therapy, and had been to Rupert McShane's clinic in Oxford and spent a day with him. Somehow had a ketamine experience, I don't know how they engineered that one, but then set up a clinic straight off one experience. Then, his first patient had a really out of control experience, was really disturbed, and he just had no experience. And I think, this is a sense of Jamie Wheel is, how are people, if people are being that impulsive about setting up this stuff, how are you going to contain and hold someone?
I know what ketamine does. So I tell my patients, you're being under all these substances, except for MDMA, where you're actually talking to the patients. Under these substances is not the time when you want to engage the patient in dialogue, or you want them out into the committee of thousands in their heads talking to themselves. So listen, I tell them, listen to the music like you are a musician in that band. Pick an instrument, make believe you're playing in front of an audience of 30,000 people, and if you make one wrong note, everybody's going to notice. That is meditation, and that's shutting off the committee. And if you find yourself in some tangent, go back to the music. Your music is the vehicle of travel. So the music is critical. If you look at any animistic, shamanistic cultures that use this, there is always a binaural beat. There's a drum beat. They're dancing, following that beat. So I can shut off the conversation in my head and let the drug take me to where I have to go. Some of these drugs, what they're really doing are shutting down the Freudian ego protective mechanism of the brain that allows us to deal with our lies and bullshits and ego. And that's why LSD can be very rough on the ego, because he got left with my being self, Every time I have disintegration for whatever my ethical code is, the more spiritual you are going into this, the harder the trip you may be. I'm worried when I'm giving it to sociopaths who have no empathy. They will steal your shit and they help you search for it. They never figure it out. They take their stuff and they love it. I give it to someone who's super spiritual and they get stuck like if they learn and have a really hard time. You learn by doing a lot of these treatments, but I give the same exact instructions for ketamine as I do for patients who take iCAAD. Listen to the music perfectly, and it will take care of itself. If you get lost, go back to the music.
Thank you so much. Okay. We're almost out of time. We've probably got time for one more question. Please.
So if it's now going to become available in nasal form, one certainly is quite sure these patients who have an addiction history are screened out. You're relatively contraindication to prescribe them.
Thank you so much. And
Check me out. Just a minute. So consider just as you may be not wanting to prescribe benzodiazepines.
Thank you so much. Yeah, and it's something that's shared by Rupert McShane, who's running this clinic. He's concerned about it, but that is one of my worries because it's starting to be treated by general psychiatrists who don't have an experience in the addictions, that don't have a personal experience, and I think to me that's one of the more worrying movements.
I would say that these drugs that you're recommending, which talk about that, can only be adjunctive therapy. My experience is that the drugs that are using adjunct therapy are not automatically minimal benefit over.
Thank you so much. I think we could talk, exhaustively, but it's just a little introduction. Thanks so much for your time.
Thanks for your time.